this. I'm Martine Price. I'm the nurse lead with Improvement Cymru, and I'm really pleased to be supporting this session this afternoon and to welcome Annie and Sol. It's great to see so many of you have been able to join today. I know there have been some apologies, but we will be sharing the slides and the recording of the session. So this is, I know some of you attended the previous session. This is the second webinar that Annie has done for us. The previous one was in July, and that focused on staff experience. And Annie shared the real-time staff experience program that they have well established and seen many benefits to their organisation, and particularly shared that within a context of how that's evolved and supported their COVID response. So this webinar, Annie's sharing Northumbria's journey over many years and how their patient experience programme has evolved and is absolutely central to the organisation alongside staff experience. Just before I hand over and introduce Annie, I think for us in Wales, just to frame this session, we all know that we've got the Quality and Safety Framework, Learning and Improving for Wales, that was recently launched, which is integral to our safety experience and improvement work, and then the All Wales framework for assuring service user experience. So that kind of context for our thinking and going forward in Wales. Annie, it's absolutely fantastic to have you here today, and Sol, sharing your work. I've known Annie, many years now.
Yeah.
Annie began her career, she is speech and language therapist, and she obviously worked clinically and led the Northumbria stroke team as part of that. But she has for many years now been working at executive level as an executive director on the board. She's the Chief Experience Officer. I have to say she's been absolutely pioneering in her work around patient experience, making that really meaningful, and then taking that forward with patient and staff experience improvement. So really pioneering in her role and what she's achieved, and her team with the organisation. She's a Health Foundation Generation Q Fellow and a trustee of the Pickett Institute. So we're absolutely delighted to have you here today. As you can see, we are recording the session, so we will share it and the slides with you. Annie, I know you welcome questions, so if I could ask people, if you've got questions, please pop them in the chat, and there will be time at the end to pick up as many questions as you want, but also Annie's going to leave her contact as well, and we can carry that on. We will keep to time. I know you're all really busy. So Annie, I will hand over to you. Thank you very much.
Thanks so much, Martine, for that very generous introduction. Sol and I had a great session with you all in July. Always nice to be invited back. You know, that's always it's always a more positive sign. So, we're grateful for that, and looking forward to the time we have together this afternoon. So as Martine mentioned, this work, when Martine first approached me and asked if there was a chance of us developing two workshops, the staff experience one we did in July was very much a current story. It was a story of what we've done, and particularly in the context of COVID, to support staff experience. The story that Sol and I will be sharing this afternoon is one that's been longer in development. So I became Director for Patient Experience for Northumbria in 2009, and the work that we're going to be describing in the next hour or so dates back to then. So it's a decade's worth of work for our organisation. So we wanted to just check in. We know, and we talked about it last time, the link between staff experience and patient experience. So before we talk patient experience, Sol and I just want to check in with you all and find out how you're doing. So we'll wonder if you could start our presentation off for us today by clicking on the link. and that will take you to a question which will ask you to scale your motivation for work today on a scale of 1 to 10. Would you mind doing that for us? It's entirely anonymous. Nobody will know what your score is or that it's come from you, but we'll be able to get a picture for where you are. So just click on the link and leave your score quickly on a scale of 1 to 10. How motivated are you feeling for work today? Maria's asking, Sol, can someone send the link over there? I don't know if we want to put it in the chat, either the link in the chat or people want to use the QR code from their phones just to access the survey. You can. If you just use your phones to hover over the QR code, you should have access to it. Failing that, I know Sol will put the link in the chat for us. I say that live so that the slides be enlarged slightly. Sorry, old phone, I can't scan the code. If we can get the link in the chat, maybe that would help, Sol. The QR code has worked for some of you, and for others, we'll get the link in the chat. There it is. So if you can click on the link in the chat, then hopefully that will come up and just give us your idea of where you are on a scale of 1 to 10. We asked this question of you in July, and this is where you were. So on average, on a scale of 1 to 10, you gave a rating of 6.48 out of 10. The range was people giving a score of between 3 and 10. And you also left comments. A third of you left comments about why you'd given the score that you had. And we had about 54 of you, which was fantastic, responding in the moment. We just wanted to check in really and use it as a demonstration of in the moment, finding out where people are, but also grounding any discussion that we now have about patient experience in the context of staff experience too, because for us they are so inextricably linked. Okay, so moving forward, I want to tell you a brief story. When I, just before I took up my role as Director of Patient Experience within Northumbria, in the summer I went on holiday to a pretty rural part of Turkey. My husband's an ecologist, so he doesn't like spending time in busy places, and we were chasing turtles at the time in some effort. So it was a pretty remote part of Turkey. We got to the final day of our holiday. We had the children's grandparents with them, so I persuaded my husband to leave our kids with their grandparents by the pool. I said we'd hire a couple of motorbikes, pretend we were 20 again, and head to the hills. It was all going to be grand. It wasn't. I came off my bike. I went into the back of a fruit lorry. I slit my throat and was knocked unconscious. I woke up in the back of a very old ambulance, as I said, in a very rural part of Turkey, and I was completely terrified. All of my innate prejudices came to the fore. There was no bit of me that believed that what I was about to access was high quality, safe care. I just wanted to be back in the UK in an NHS that I was familiar with. So I was really, really scared. I arrived at a brand new hospital. It had been open less than 3 weeks. It was dazzling. It was so clean. And within 30 minutes, I'd had a scan, a CT scan. And within 45 minutes, I was having a conversation with the consultant within my care. Now, I was clinical lead for stroke services at that time, and I knew in 2009 that our door to scanning time certainly wasn't 30 minutes. I was transferred to the high dependency unit, and I was the first patient that nurses had seen on the unit since the hospital had opened. There were 5 of them on duty, and I suddenly thought a 5-to-1 nursing ratio was slightly different to the ratio of nursing to patients that I'd left behind. So there were lots of indicators that I was getting high quality, responsive, appropriate care in a good place, and yet my anxiety wouldn't allow me to relax. I found it very difficult. And that night, a young guy came to my bedside. He worked in on reception downstairs at the opening of the hospital. And he said, "Look, I know nothing about healthcare. In fact, my background is in the hospitality industry, but I'm imagining that you're very frightened. You're a long way from home." And he said, I can't offer you any help with your injuries. He said, "But my English is excellent." He says, "I can come and see you every day. And if you have questions, I can make sure that those questions are asked on your behalf." So it was an act of kindness. It was a relatively small act of kindness, and yet the impact for me was huge. I suddenly felt I was in exactly the right place, receiving the right care, and I was able to relax and start receiving the care that was being offered to me. And that was somebody from the hospitality industry that was able to see what it was that I needed in that moment, in the context of my clinical care. And I tried to imagine a Turkish guy falling off his motorbike in Ashington in Northumberland and being transferred to one of our wards. And if he couldn't speak English, could I be confident that he would get the level of support, rapid access to a translator, and somebody going to reassure him just because they knew that he was frightened and a long way from home? So it was a really important lesson for me that when I accepted the new role as Director of Patient Experience in December of that year, that I should measure the things that patients cared about the most and the sorts of things that they lay in bed frightened about when they are receiving healthcare. And I touched on this last time. The other important thing is that we can't think about improving patient experience unless we do that alongside the hard job of also understanding staff experience too. So the evidence around patient experience is extremely clear. The evidence around person-centeredness and the benefits of person-centeredness has been around since 2005. In 2013, there was an extensive systematic review that really confirmed that patient experience isn't this pink and fluffy add-on. It is consistently associated with patient safety and clinical effectiveness, and that we run the risk of sidelining experience and interpreting patient experience and seeing it as something that's too subjective or too mood orientated and divorced from the real work of improving patient safety and clinical effectiveness. The evidence is also clear that organizations that are more person-centered are safer, and they will provide better clinical care. And engaging people in their own health care, improving that partnership with patients, not only improves people's knowledge, but also it impacts on the experience of their service. It impacts on how they use healthcare services and the cost of that, as well as having a direct link to their own health. And as I experienced lying in an unfamiliar bed initially, my anxiety and fear got in the way of my own healing. And it was the kindness of someone who was able to address my anxiety and fear that made the difference with respect to recovery. So pay attention to human connections, pay attention to empathy, because there's a lovely quote to say, we must remain in tune with human connection in order to form lasting and trusting relationships with our patients, because it is only then that we'll be able to provide the highest quality of care for patients who deserve that, and so much more. So in the slides that follow, I'm going to run through them quite quickly. You'll then have your own copy to digest in your own time, and do come back to us if there are any other questions that you want to ask following today's presentation. But essentially, I'm going to tell you a little bit of the story and the things that we pay attention to. It's not so much a recipe book, but it is core things that we have perhaps focused on that has helped us change and shift our focus as an organisation over the last decade. So in 2007, only 43% of Northumbria staff believed that the number one priority of the organisation was on high quality patient care. And the latest staff survey is that figure has changed in my organisation over time from 43% to 91% last year. When I first got the post as Director of Patient Experience, I had two very simple aims, really. I wanted to make a meaningful contribution to patient and family experience and care. And I knew then that in order to do that, I needed to also support staff in order to ensure that they were able to provide the sort of care that they would want for themselves and for their families. So I'm going to take you through the 6 things that I think we've paid particular attention to, and hope it resonates with some of your experiences in the improvement work that you're doing in Wales. And the first of these is that we've needed leadership at every level of our organisation, focused on compassionate care and service improvement. That 19-year-old in Turkey saw it as his role to make a contribution to compassionate care for me. He had something to offer, and it made a significant difference for myself as I lay frightened in an unfamiliar hospital bed. So if we want to engage our staff at every level of the organisation, we need to make sure that they have at least 3 things. They need coherence, and by that we mean they need to understand how their role plays a part in the commitment of the organisation to person-centred care. We need to be willing to listen to their ideas for change, because within that will be the creativity we need to make changes. And we need to make sure as an organisation that we're not putting bureaucracy in the way of patient contact. People have gone into healthcare for a reason. And sometimes in the effort to improve things, we take them further and further away from regular contacts with patients. And that can have a very detrimental effect, not only on the quality of patient experience, but also on staff experience too. Because the provision of compassionate care is not only good for patients, it also nourishes the caregiver too. So we have wide level engagement on an annual basis every year to decide our priorities for quality. We have performance reviewed at every level. I'll talk about the importance of transparency and honesty later on in this presentation. But all of our improvement efforts, the aim is to, in partnership with patients, make sure that staff clinically led, that change is clinically led and based around changes that is as close to staff and patients as possible. So I talk about this being a favourite slide. It's a very old slide, but for me, it highlights the complexity of improving patient experience and patient safety and quality in healthcare. So this was some of our effort to reduce surgical site infection after hip fracture care. And the point that I want to make is that in order to successfully reduce that and to see the gains that you see on this chart, in this run chart, it needed 20 different teams across our organisation, some clinical, some not, trying more than 25 different ideas before we achieved the levels that we were happy with. And that for me is the nature of improvement work, and the complexity of that we need to appreciate. But the level of involvement of as many people as possible in that, quite key to success, we feel. The second component of our programme is grounded in capturing as the voices of as many people as we can and using those insights that we receive from patients and families to improve care. So we have a programme that listens to the views of more than 50,000 people every year. That measurement framework is evidence-based, wrapped around the evidence around what patients care about most. So we looked at the evidence around the key features of a positive experience in hospital, for example, and those are our core metrics in our real-time programme. Our real-time programme involves speaking to approximately 700 patients every month, whilst they're still with us, occupying our hospital beds, and having good insight into what we're getting right for them in the moment and what we could change and improve. We feed that information back to clinical staff within 6 hours of talking to patients. So it's really timely information that we can be nimble in our response. And then we recognise that the evidence is also clear. 2 weeks after leaving hospital is a time when patients report feeling the least happy about their care. Maybe the pain control isn't under control. Maybe the transition out of our hospital buildings was less coordinated than we thought it might be. Maybe the community follow-up and promise hasn't happened in the way that we said it would. So we deliberately target that 2-week period when patients are statistically at their least satisfied. And we call it our right time measurement because it's the right time to understand where our greatest improvement opportunities lie. We talk about making toast with our data, essentially ensuring that people have access to that information in a really timely way, that we're not overwhelming people with the 550 things that they have to be better at by next week, but it's a manageable number of core domains that are evidence-based, that we're really specific about where the improvement opportunities are, and we make sure that this programme was talked about widely across the organisation and commit to doing that in a variety of ways. We work in partnership with third sector organisations. So this was great work that we did to improve healthcare, outpatient experience of people with learning disabilities, working with Health Quality Checkers team and Skills for People. We've worked with older age charities, older people themselves visiting our wards as advocates for people with dementia and delirium, to witness the care that we give in the moment and see what opportunities we're taking to promote dignity and those that we might be missing. Our measurement programme every year is underpinned by an agreed and recorded equality, diversity and inclusion improvement programme. So this year we will be doing work to improve the family experience of people with dementia. People with learning disabilities have worked with us, as well as Learning Disabilities Northeast Network, to produce cards, accessible cards to support conversations in emergency care and in outpatients. Young people have helped us radically redefine and change the way we capture patient experience with a younger person in mind. And also people with mental health challenges helping us understand. Sometimes we've learned to be more creative with our engagement approaches. So fantastic work to partner with refugee community, Syrian refugee community in Northumberland, and build trust before we started that work. And one of the ways we started that was to set up a football league on a Sunday that brought healthcare workers and representatives from the Syrian community together on a Sunday to play football together before we did the hard job of understanding what we need from the healthcare services when the level of trust in an unfamiliar wasn't at its best. And there were many people that were failing to access healthcare in a way that would be useful because of their fear of what would happen when they do, and whether culturally some of the things that they really valued would be compromised in a healthcare environment. We've held bush tucker trials with young people to explore sexual health and feedback. A focus group by any other description, but it's when it's done in a Northumberland round a fire, we can talk about other things that are important to young people in a way that probably improves engagement and the feedback that we can receive. So be flexible about how you ask the questions and the way, and rather than expecting people to come to you, be willing to go to where people are, some of the lessons that we've learned. When you get that information, be sure to be honest with people about what you found and share it as widely and as transparently as you can. And this takes courage. It's hard to share information you're not proud of. But the faster you do that and the more comfortable you get about doing that, we've learned the faster we get at changing some of that feedback for the good. So we've learned how to be really honest about our current state and transparent in that all information that we capture around patient experience is available for patients, for families, and for our wider communities too. On our websites and across all of our hospital and healthcare environments, you'll see posters like this, updated regularly, but giving you a flavour for the latest experience feedback that we've received. So the poster in red, a list of our top 20 consultants based on the feedback that we've received from patients. This is a really, really lovely definition of dignity. It came from an 83-year-old gentleman who had done work with Wyn Tad in her qualitative investigation of dignity in acute hospitals. And we've adopted that as our definition of dignity. But the point I'm raising here is that we're able to understand dignity at every level of our organisation. We measure it, we can understand it at team level, at hospital level, at site level, at specialty level, because there is variation in dignity across our patch, and our measurement framework allows us to understand that variation and use it to support improvement. This was a mouse map that we created for clinical teams that had been involved in working in partnership with patients and families to redesign hip fracture care. And at the end of a very successful program, we produced this mouse map so that every day, from a sustainability point of view, when people were running their mouse across it, they could, one, be proud of what they had achieved, but also be mindful of the work that we were keen that we sustained as an organisation. And using that data to ensure that we are an organisation that feels very comfortable about raising concerns and having a number of governance processes in place that allow us to be very clear about, you know, using 15 steps or safety walkarounds at a board level, or safety films where patient experience has been fallen below the standards that we would like for the organisation, and a courage to share that information so that we can all learn from it. That has influenced our culture over time. If you look at the national results, for psychological safety for Northumbria and raising concerns, we will be amongst the very best trusts in the country around people feeling very, very safe to say when something has not gone right, and confident too that something will happen when they do raise concerns. I got my job as Director of Patient Experience by writing to my Chief Exec in 2009 and asking a question about what we were doing about person-centeredness in the organisation. So we've been able to use that information to improve and then rely on that data to evidence the outcomes as a result of that improvement. We've become a safer organisation over time, and we've seen our patient experience radically shift over time to a leading level 1 decade down the line. So we're very proud of where we've ended up, but it wasn't necessarily where we began. We can understand measurement at different layers of our organisation. So at an organisational level, when we first started this work, we were ranked 111th in the country out of about 160 NHS English trusts, and that's changed since 2012, where we managed to achieve top 10% position, which we've been able to maintain over time. Northumbria beaten only by single specialty organisations that don't have ED departments, and this is great company for us to achieve in this. We want to aspire to offer the kind of care, elective care, that's been offered at the Christie or Royal Papworth. We know that the urgent care experience is very different from an elective experience, but it's lovely to have that to strive and aim to achieve. And we can see where the North East tends to fare very well with respect to patient experience, but pleased that we've been able to lead the way for a number of years now. We can understand our performance at a site level too. We have 11 hospitals right across our complex patch, and in 2015 took an important strategic decision for the organisation to open the first emergency care hospital of its kind in the country. So really important then that we had the mechanism within patient experience to measure what that change of direction and reorganisation of our clinical pathways meant for patients. We had feedback from more than 13,000 patients in that first year of service delivery. And these were all the things on a slide that were statistically better within that first 12 months. But because we've got a strong historical capture of patient experience, we've been able to make those comparisons of what care has been like before and after the opening of the Northumbria Hospital. And you can see those on your slide there. That link between patient and staff experience is really important for us. So every 3 months in every one of our hospitals, this poster will be updated. And on one side of the poster, you'll hear from patients about what it's like to receive care in that hospital, the latest picture. And on the other side of that poster, what it's like to work in that hospital according to staff. Again, we will get variation across our 11 hospitals, and that variation inspiring us to change and improve over time. We have regular updates for clinical teams at a ward level. So if you're a ward manager, expect for your team and your ward to be visited twice a month. You don't really know when they're happening, but you'll know that happen at least twice a month. And we can note the changes that have been taken place. This is an orthopedic ward, and historical measurement in blue and later measurement in red. The statistical benefits and changes in each of those core domains of patient experience that are evidence-based. So we can look and map improvement over time. And because we've got a long period of time of measuring patient experience, we've now got all of our ward level reporting captured in SPC charts so that we can be really nimble about any meaningful variation. We're not asking teams to compare what they're doing with the ward next door, because quite frankly, the ward next door are caring for a different group of patients with a different team themselves and facing different challenges. What we're asking teams to do is know your own baseline. What do patients think about your care last year? And what are your latest SPC charts telling you about where you need to improve and where that meaningful change has or hasn't happened? So this is very common information to be sharing with our clinical teams over time. As I mentioned, if you're a consultant in Northumbria, what your patient said about you last year gets compared with what they're saying about you this year, and it is fed through your appraisal alongside the performance of all of the other consultants within your specialty. Again, this is not measurement in a punitive way or a judgmental way. It's measurement for improvement so that we can provide individuals, teams, services, hospitals with the support they need to be better. So this is again very transparently shared and owned and promoted by medical staff within our organisation. I think the other thing that we've paid a lot of attention to is a celebration of kindness and compassion. In the process of measuring patient experience, my team have the privilege of listening to stories, phenomenal stories, every day about what it is that healthcare professionals do to contribute to enhance patient experience. And the honest truth is, without a patient experience measurement in place, those stories were happening in our organisation and we were walking past them. And we were missing opportunities to celebrate the teams that were responsible for that high quality and compassionate care. So unearthing stories, paying attention to stories and the power of stories, but also recognizing that stories are told at a price to the storyteller sometimes. So sometimes those stories are about harm, and we're asking people to revisit those incidents. And I think capturing stories comes with a commitment to act on those stories, so that we can honestly work in partnership with patients to say that something has happened as a result of the information that they shared. I won't delve into all of these personal stories. We've gathered hundreds over time. We make films about them. We make noise about them, and we celebrate staff as a result. Away the Lads one was about a really junior member of staff working in critical care, Sarah. And she was caring for a 27-year-old who wasn't going to leave the unit. And he was someone who, fanatical Newcastle United supporter, who every time there was a home game would go out with his mates, drink a few Newcastle brown ales, and go to the match. Sarah didn't ask permission, and she didn't think it was outside of her job description to find a way of, and this was a challenge because IT access in Northumberland historically has always been challenging, but she got a Newcastle United match streamed to the ward in critical care. He could no longer swallow at this point, so she got Newcastle brown ale. She persuaded someone in catering department in our kitchens to freeze Newcastle brown ale lollies, and she invited his mates round. And 4 days before he died, he watched another Newcastle United match with his friends, with a round of Newcastle brown ales, albeit in a different format than they usually had. Sarah was nominated that year to receive the Chief Executive Award for Compassionate Care. And it is the best example that I have of leadership at every level of our organisation, taking forward the patient experience agenda. I believe every organisation will have all of these stories in abundance. And it's patient experience measurement that has allowed us to uncover them and celebrate them. And the final thing that I think we've paid particular attention to is working in partnership with patients and families for improvement. So just in the text, without overthinking it, can you all just give your definition of what co-production means to you? Who's going to be brave enough to type the first definition of co-production? Finding a way together, that's nice. Working together for the greater good. I like that, start to finish. That's something, it's not an add-on at the end. Okay, so Sol's going to caption all of these great definitions for us that has come from an improvement community in Wales. So thank you for that. I'll be able to use them. This is a lovely definition. And you've touched on it already. It means designing and delivering service in an equal and reciprocal relationships between professionals, people using services, their families, and their neighbours. And they give, or Demilla gives this really lovely equation, which is it's a combination of expertise and appreciating difference and variation in expertise, plus partnership that will allow creative solutions to happen. I quite like that definition. What stops us? Again, can you use the chat just to, because if we all generally agree that it's a good idea and that it delivers the things that you've already put in your definitions of collaboration, permission to do it, right? Okay, time, a big one, resources, permission, fear of doing it. Okay, thanks, Gareth. That's really honest, and I think it's a common one. People are sometimes frightened of not doing it well, frightened they don't have the expertise, and so avoid doing it altogether. Not understanding it or understanding how to approach it. Sometimes Stacey acknowledging it's just the bureaucracy of getting in the way and it becomes more trouble than it's worth. Fear of vulnerability. Thanks, Bethan. Quite in the partnership working, it's quite liberating, I would argue, but also quite frightening to walk in the room and leave everything, or titles or things that we hide behind sometimes as professionals outside of the door, and really join with people and with a willingness to be vulnerable. Acknowledging that there is a power struggle in the room, and sometimes having that work really well facilitated so that you address the power indifference, really important thing that Tanya has raised. Thanks for that. Keep them coming. We'll be able to summarize these at the end. But that partnership for me in improvement is essential, because quite frankly, regardless of where they are in our hospital systems, in the community, or in our acute organisations, patients and families see things that we don't see, and they hear things that we certainly don't hear. So if what we are about is improvement, we need to have their involvement, their active involvement and engagement from the very beginning, because we will get it wrong without a strong patient voice. We will have a skewed picture of what it is that we need to change, and we will miss something vital. So this definition of a touch point is taken from experience-based co-design methodology. We use it as the improvement method in much of our work. And Bates and Roberts defined a touch point as any customer experience that makes a significant and lasting impression on how they feel about the service. It won't necessarily be the process points that we want to take them to. They will be unique to patients. So my question to the group is, what touch points are staying with your patients when they reflect on care in Wales? And how do you know that? How are you capturing them? And then also, importantly, how are you sharing that information with your teams? And I know you're doing fantastic work in the development of your new improvement frameworks that link to patient experience. And I was really glad that Martine was able to share those with me in advance of the presentation today. But it's worth holding these things in mind and how tight that link is, and that conduit between the patient experience measurement and the things that patients want to tell us, and giving that information in an accessible way to staff that inspires them to do something with that information for change. I wanted to give you just an example of that partnership working. We've got many examples, but this is one that, because it's relating to stroke, is quite close to my own heart. I worked with a health psychologist and a stroke information coordinator to develop a 30-hour training program for stroke peer supporters. I wanted to develop a new way of providing a link for our patients that had been newly diagnosed with stroke, and that experience and common experience that can be shared. So we recruited 23 volunteers. Some of those were people with stroke, some of those were carers of people with stroke. And we invited them to attend a 30-hour training program. They came for 3 hours a week over a 10-week period. We gave careful consideration to their diverse needs. The resources that we produced were accessible for people with aphasia, people with visual impairment, and people with memory loss and other cognitive difficulties. And we also made sure that as peer supporters, they were buddied up with another peer supporter and had access to supervision and support from the provider organisation, namely Graham as a health psychologist and myself as a speech and language therapist. We interviewed and recruited, as I said, in a normal HR process, 23 volunteers, and in the first 2 years of that program, there was no attrition. None of those 23 volunteers. We all changed our jobs in that time. There was lots of movement within the stroke team, but the stroke peer supporters remained constant and delivered more than 400 visits in that first year. So this wasn't just about co-production. It wasn't just about learning about where we needed to be better or improve the stroke service. It was actually revisiting the model of rehab model and knowing the role that patients themselves, family members and carers could play in delivering a service in their own right. In that first year, more than 400 visits were made to people with stroke as they lay in our hospital beds. And I just want to, I hope the audio's on, Sol. I just want to play this video of one of our peer supporters and what it meant for them. Oops.
Two seconds just get rid of share again.
Thanks, Sol. Thanks for rescuing me.
The reason I got involved in the first place was I asked my sisters what they would have liked when I was in hospital, which, by the way, I don't remember being in hospital. And they said they would have liked to have talked to someone who'd been there and experienced it. Not all the information that we're given, all the technical information, just a real person who'd been in a real situation and they'd come out the other side.
I got involved in the programme because my husband had a stroke. I had a stroke 2 years later, so I can see the people's perspective from 3 angles: as a patient, a carer and a volunteer, really, because I saw it from 3 different angles, and maybe that would have helped people that I spoke to. The training did prepare me for the role. We did a lot of work talking about our own experiences, which was very good because it kind of made you face the reality of that, if you like. And we're very supported by other people. It was interesting to hear how other people had coped with their experiences.
The training, I was worrying going into that, but it was excellent. There was so many things that I realised. Other people, there were stroke people and different types of strokes and all different emotions and different things like that. Well, I have aphasia, so I went in. I must admit, I did think I might have a bit of a problem. Everything had been done simpler for aphasia as well. I did enjoy that.
The training that we had was very good because it involved a lot of repetition. It was reinforced all the information we were given, and it was over a long enough period of time so that we really felt knowledgeable, informed and prepared before we actually went on the ward. It was really good. And the hospital visits, we come every week or every other week. It varies. But we're normally with patients about 40-45 minutes, and we see as many as who want to be seen.
The time for the programme is when you're going into the ward, it depends. I don't think we can go in thinking, oh, we're only going for 10 minutes or whatever. You have to wait and see how the patient is. Sometimes it could be a 10-minute one where they're full of tiredness or whatever. It could be half an hour when somebody's got a lot to tell you. So, and there's no point, we shouldn't be looking at the watches and everything, just to take the time.
I think as volunteers, we are treating the social side of stroke more than the medical side. We are realistic but very positive with them. We can address post-stroke issues because all of us have been there and know what it feels like and how frightening it is. And we can sort of give some sort of insight as to what real life will be like once they're discharged from hospital.
When I've met somebody in the ward, I normally always go back when people have been in for a long time because we get the good rapport with each other. And that's a nice thing, that you know that they're waiting for you. So it's just very nice.
It's one of the things that I really want to do. So it sort of takes priority over everything else I do.
You feel quite proud when people don't want to talk to people, but now they're chatting away to everybody because you get them to keep the humour. And it's, oh, that's fantastic when you see them starting to bloom. That's the best word for it.
I know I've made a difference. What's different about the Stroke Support Volunteer Programme is it's patient driven. And I've had a stroke, and the patients appreciate the fact that I've had a stroke and I'm more or less recovered. I mean, sitting talking to me, you can't tell I haven't got a memory and I'm half blind. And I tell them I've had a stroke and they realise it is possible, not guaranteed, but it's possible to recover.
I think it's made me come to terms, if you like, with my situation more because I've had to look it in the face and cope with it. Right. I do feel it's been quite useful for me to talk to other carers and to be realistic with them as to how it's going to be like when they leave hospital.
What it's meant to me to be involved in this stroke support system is that it's given me a confidence to actually do something useful.
I feel as if I've done something. It's given me so much. It gives a buzz when you just feel that it's something right. Things that I would never have done with going to the gym and aqua aerobics, I've abseiled. I would never have done with things like that, but I keep thinking about the stroke, and it's where we are. I think it's a great thing. It's like a family with the stroke club, everything like that, and we have all great friends. You know, it's really good.
I'm proud of a lot of things, but the main one is it's a patient-driven experience.
Sorry, I think we just lost that. That was the end of it.
Patient.
Okay, I'm just conscious of time, Martine, and we've got about 5 minutes left before the end, so we'll probably call it a halt there. I know I've chucked a lot of information at people, but I hope it gives people a flavour of our programme and how we've developed that over time. And happy to take some time now to answer any questions that you may have. Thanks.
Thanks, Annie. Yeah, very conscious of time. I've been picking up the questions as we've going through, so if we could take a couple, that would be great. Claire asked earlier on about how do you specifically engage with people who have a sensory loss?
In terms of the stroke peer supporters?
I think more generally in terms of how do you gain feedback from how do you survey people with a sensory loss? What methods do you use?
So we have access to signing, and so we've got it's the best way to describe it, a portable availability on our wards where people could have immediate access to signing, if British Sign Language if they need it. We can get auditory reports, people with visual difficulties, so the engagement from the patient experience coordinators at bedside is a face-to-face conversation, so people that can't read and complete a survey could engage in that conversation in a different way. We've adapted the language in our surveys to support different communities too, in terms of accessibility of the language used and visual cues to support understanding, if that might be helpful. So a variety of different ways depending on the need.
Thanks, Annie. There are a few questions around the poster that you put up with the top 20 consultants.
Okay, yes, usually.
So one of those was, do you name the consultants, and is there any feedback from patients because they might be worried if their consultant's not on the list? And how did you create psychological safety between consultants to be able to do it?
Okay, all really good questions. We do name the consultants, and they are shared in areas so people can see that. It is 20 names. We don't share the names of our bottom 20 consultants. Clearly, it's the top 20 of hundreds of consultants within our body that whose names are shared. In recognition of celebrating that, I think it's important to get that out. We haven't had feedback from patients about worrying about their consultant and doing that, but I mean, I can accept that would be a risk, but it's not been the case, and we would capture that patient experience anyway, so they have a mechanism of telling us if that is the concern. That hasn't been addressed. I think the psychological safety thing is a really, really important issue. And I think that we've done this work, I think I have to say, is over a long period of time. There's something about the culture within our organisation that has made that possible to do. And I think the only thing that can contribute to the development of a safer culture is, one, that action happens in support. And in sharing information, punitive actions don't follow that. So people aren't on the receiving end of judgment should their scores fall below an average score, but what they actually feel is an improvement and a supporting mechanism that the organisation recognises, that's our duty to provide and support with. So I think getting the culture right is exactly right. And the information isn't shared in a disrespectful way. The consultant staff, in terms of their appraisal, have influence of who is supporting them in those conversations and who will support them in the event of any improvement work that needs to be done too, and they have control over that. And ongoing discussions with the consultant body about the way that we present that information and share that information. If anything, they've asked for more of it, not less. So, but I accept it's happened in a culture where this is seen as a positive contribution, and was really well led by senior medics in the organisation in order to make it happen in the first place.
Annie, thank you. That's really good to hear. I think we're going to have to stop there in terms of questions. There are loads of other questions in the chat. I know you're happy, and you're going to give your contact for people to make contact in terms of those questions. I just wanted to say thank you so much, Annie, for sharing such an energizing, inspiring session. I think so much there for us to take hold of, and I just love the fact that, you know, why wouldn't we get feedback